Hello everyone, welcome back to the series on cardiology lectures. Today we will be looking at diseases of the pericardium. Okay, so let us begin. So as we all know, the pericardium is the outermost layer of the heart, right? So the heart comprises of the endocardium, the myocardium and the pericardium. So there is a thin layer which surrounds the heart which is called as the pericardium. So the pericardium is classified as the parietal pericardium and the visceral pericardium, and it has a minimal amount of fluid which is present between the parietal and the visceral pericardium, which is about 15 to 30 ml. So there is a minimal amount of fluid which is present between the parietal pericardium and the visceral pericardium, and this is about 15 to 30 ml. So the pericardium basically acts as a cushion for the heart. Okay, fine. So now let us look at the different types of pericardial diseases. So the first disease is the pericarditis. So what is the meaning of pericarditis? So whenever you see this word itis, it basically means inflammation. So whenever you see this word itis, it basically means inflammation. So pericarditis basically refers to the inflammation of the pericardium. So let us look at some of the most important etiology. So when it comes to the etiological classification of pericarditis, infectious is the most important cause for pericarditis. So infectious diseases are the most important cause. So out of which viral is the most common cause, right? So Coxsackie virus, echovirus, herpes, mumps, adeno, hepatitis, HIV, all of these can cause pericarditis. Apart from that, this though rare, you can have fungal and tuberculous pericarditis. Tuberculous pericarditis is very common in our country, whereas bacterial pericarditis with pneumo, strepto, staphylococci, legionella is slightly rare. Then fungal infections and other infections like syphilis, which can also cause pericarditis, right? Then we look at the non-infectious causes. Non-infectious causes, we have idiopathic, then we have renal failure. Malignancies can cause pericarditis, right? So this can be benign or malignant tumors, mesotheliomas, and tumors with metastasis to the pericardium can cause inflammation like lung and breast CA. Trauma can cause pericarditis. Aortic dissection can cause fluid leakage or blood leakage into the pericardial sac, and this also can cause pericarditis. Fine. Now, post-radiation and familial Mediterranean fever and periodic fever syndromes. These are basically a group of syndromes which are associated with disorders of interleukin-1 pathway and the inflammasome pathway, right? So the interleukin-1 pathway and inflammasome pathway is the pathway which is involved in these group of disorders. Metabolic disorders, myxedema, can cause pericarditis. Apart from that, autoimmunity, right? Autoimmunity, most importantly, collagen vascular diseases, rheumatic fever, then drug-induced pericarditis is very important. The drugs which cause SLE, you know, right? The SHIP group of drugs which is a mnemonic which is famously used, to remember that. So similarly, we mainly have the procainamide, hydralazine, INH, minoxidil, all of them can cause drug-induced pericarditis. Post-cardiac injury, post-traumatic and post-MI. The pericarditis that happens post-MI is what we call as the Dressler's syndrome. The post-MI pericarditis is what we call as the Dressler's syndrome. Okay. So that is about the etiologic classification of pericarditis. Now, what about the clinical classification? So, classification of pericarditis can be based upon the duration. So, this can be classified again as acute, subacute and chronic pericarditis. So, this can be classified again as acute, subacute and chronic pericarditis. Acute is less than 6 weeks, subacute is 6 weeks to 6 months and chronic is more than 6 months. So, acute is less than 6 weeks, subacute is 6 weeks to 6 months and chronic is more than 6 months. Okay. So, acute pericarditis can be fibrous or effusive, then subacute can be your effusive constrictive and chronic pericarditis can result also in constrictive pericarditis, right? So, that is about your etiology classification. Let us move on to the clinical features. So, the first and the most important clinical feature is that there is chest pain. This chest pain is not your ischemic type of chest pain. So, you can have a chest pain which is basically radiating to the trapezius ridge. It radiates to the trapezius ridge, right? And this is worsened on lying down. And it is relieved by leaning or bending forward. So, this type of chest pain or pericardial chest pain is relieved by bending forward and it radiates to the trapezius ridge and it's increased by normal activities like coughing or even during respiration the pain can worsen. So, that is your classical chest pain of pericarditis. So, the second most important thing that you will have to know is this sound which is called as the pericardial friction rub. So, the pericardial friction rub is basically a triphasic sound. This is a triphasic sound. Where else have you heard a friction rub, right? You have heard it in your pleuritis. So, this is a scratchy sound. This is a scratchy triphasic sound which is heard over the pericardium in pericarditis. And what are the three phases? Ventricular systole, ventricular diastole and atrial systole, right? So, pericardial friction rub is basically a triphasic sound which comprises of ventricular systole, ventricular diastole and atrial systole. Okay, fine. Unlike the pleural friction rub which you get in pleurisy, pericardial friction rub persists even with the beginning of the effusion. As the pleural effusion starts to build up with pleurisy, the pleural friction rub, the pleural friction rub disappears, but the pericardial friction rub persists even with the pericardial effusion beginning. Okay, then we have something called as the Ewart sign. So, what is this Ewart sign? Let us just look and understand this with the help of a diagram. Okay, so this is the view from the posterior aspect. This is the view from the posterior aspect, and we have the pericardium which is here. The pericardium which is here, as there is enlargement and there is pericarditis and there is some amount of fluid buildup in the pericardial cavity. What happens is that this comes and compresses over this particular portion of the lung. This compresses over this particular portion of the lung which is present in the inferior angle of the scapula. So, what happens is that in toto, because of the compression, this acts like a consolidation. This acts like a consolidation. So, when there is a consolidation, what happens? When there is a consolidation, this results in bronchophony. This results in egophony, right? So, this bronchophony and egophony which is heard in the posterior aspect in the infrascapular area because of the pericardial fluid in pericarditis is what we call as the Ewart sign. Okay, fine. So, these are about the clinical features of pericarditis. Now, let us look at the ECG changes that you see and the diagnosis of pericarditis. Stage 1. In stage 1, you see diffuse ST segment elevation and you see TP segment depression, which is also called as the Spodix sign. Okay. So, in stage 1, you have diffuse ST segment elevation and TP segment depression, which is called as the Spodix sign. So, in stage 2, what you see is there is T wave flattening. There is T wave flattening. Then, in stage 3, there is T wave inversion. There is T wave inversion. And finally, in stage 4, there is normalization of all the ECGs. There is normalization of all the ECGs. Right? So, we have the stage 1, 2, 3, 4 in pericarditis. In the first stage, you have diffuse ST segment elevation and TP segment depression, which is called as the Spodix sign. In stage 2, there is T wave flattening. In stage 3, there are T wave inversions and stage 4, there is normalization. Okay. So let us look at this ECG. What are you seeing here? You are seeing diffuse ST segment elevation. But is this an MI? No, because first of all, MI does not involve all the leads, and you can find a concavity which is upward or a smiling face. Concave upward ST segment. Right? So concave upward ST segment is what we call as this smiling face appearance, which is seen in pericarditis. Okay, so that's how you differentiate the ECG of pericarditis to an ECG of MI. Okay, fine. On the echo, what will you find? On the echo, you will see that the heart is surrounded by the pericardial fluid. Right? On the echo, you see that the heart is surrounded by the pericardial fluid. Now, how do you manage? How do you manage? So, when it comes to the management of acute pericarditis, most of the time pericarditis can be self-limited, right? So, you give them aspirin. The aspirin is given at a higher dose of 2 to 4 gram per day. You give them NSAIDs like indomethacin, and you can also give them colchicine, especially in recurrent pericarditis. Whenever there is recurrent pericarditis, because maybe secondary to an underlying connective tissue disorder or infections, you give them colchicine at a dose of 0.5 mg per day, and you can continue it for a prolonged period of time up to 3 months. Right? Glucocorticoids generally have no role, only very rarely we use glucocorticoids in the management of pericarditis. Fine. So, this brings us to the end of pericarditis. We have learned about the etiology, we have learned the classification, we have learned the clinical features, ECG findings as well, and how do you manage acute pericarditis. Fine. Now, let us move on to the second pericardial disorder, which is the cardiac tamponade. Now, what is the cardiac tamponade? Now, cardiac tamponade is also having the same pathophysiology where you have, so cardiac tamponade is also having the same pathophysiology where you have fluid surrounding the heart. Right? You have fluid surrounding the heart. But what happens is that when there is accumulation of this fluid, there is a uniform pressure on the heart which is generated. Right? So, what is the cause for this accumulation of fluid? This can happen due to anything. It can happen due to trauma, where there can be blood in the pericardial cavity. There can be aortic dissection, and if it dissects into the pericardial sac, there can be pus in the pericardial cavity because of some infection or post surgery. Or let's say that there was a sternotomy scar which got infected, and then there is pus in the pericardial sac, or even in inflammatory conditions and malignancies. You can have a huge amount of fluid in the pericardium, and when it applies pressure, it results in cardiac tamponade. So, there is a triad of clinical features which are seen in cardiac tamponade, and this is what we call as the Beck triad. So, what are the components of this Beck triad? There is hypotension, elevated JVP, and muffled heart sound. So, there is hypotension, elevated JVP, and muffled heart sounds. So, this triad of hypotension, elevated JVP, and muffled heart sounds is what we call as the Beck's triad of cardiac tamponade. Now, let us look at the signs. So, what are the signs of cardiac tamponade? The first one is your pulsus paradoxus. If you just revisit this chapter on pulse, I have discussed the mechanism of pulsus paradoxus. Let us just briefly discuss it again. So, what is this pulsus paradoxus? So, there is an exaggerated inspiratory fall in the blood pressure by more than 10 millimeters of mercury. So, there is an exaggerated inspiratory fall in the blood pressure by more than 10 millimeters of mercury, and this is what we call as the pulsus paradoxus. So, what happens here in this pulsus paradoxus is that during inspiration, there is an increased venous return to the heart. There is an increased venous return to the heart. If the venous return to the heart increases, what happens is that there is more exaggerated interventricular dependence. The RV begins to fill. However, this is counterbalanced by the pressure generated by the fluid around the heart, which is your tamponade. So the RV cannot expand anymore. So the RV expands at the cost of the LV. The RV begins to expand at the cost of the LV during inspiration when there is an increased flow to the right ventricle or the RA-RV side. So what happens is that the increased venous return causes RV to dilate at the cost of the LV. So the septum bulges to the left. So if the septum bulges to the left, what happens? The cardiac output decreases. The cardiac output decreases. Now, if the cardiac output decreases, naturally during inspiration there is an exaggerated fall in the blood. Okay. So, this is what we call as the pulsus paradoxus. And what is the paradox here is that the heart sounds are heard but the pulse is not felt because the cardiac output is so low that it is not transmitted as a pulse at all. And this is what we call as the pulsus paradox. Okay. So, till here clear? So, what happens in pulsus paradoxus is that in inspiration when there is an increased venous return, the RV dilates at the cost of the LV and the septum bulges towards the LV. So, the output or the cardiac output decreases because of the tamponade. The RV cannot expand further and it expands at the cost of the LV. Fine. So, that is about your pulsus paradoxus. What happens to the BP? The BP is low. What happens to the JVP? In cardiac tamponade, there is a prominent X-descent. Now, we all know what is the X-descent due to? X-descent is due to atrial relaxation. So, atrial relaxation is what is responsible for the prominent X-descent. What happens in cardiac tamponade is that the atrium relaxes under a high pressure. There is a high pressure which is generated because the fluid from outside causes compression, right? So, that's why there is a prominent X-descent. Okay, there is a prominent X-descent. Now, what happens to the Y wave? The Y wave is basically occurring because of what? Because of atrial emptying. In cardiac tamponade, what happens is that during diastole, there is a uniform pressure that is generated. So, there is a uniform impediment to the flow of blood. So, if there is a uniform impediment to the flow of blood, the RA-RV pressure becomes equal. So, if the RA-RV pressure becomes equal, will there be a pressure gradient for the blood to flow from the RA to the RV? No. That is the reason why there is an absent Y descent. Okay. So, that is the reason why there is an absent Y descent. Okay. Now, what about the Kussmaul sign? Now, what is the Kussmaul sign? If you go back to the lecture on JVP, you can understand all of these much better where it is explained in a detailed fashion. As of now, Kussmaul sign is what is? Normally, there is an inspiratory fall in the jugular venous pressure, right? But if this does not happen and there is a paradoxical rise in the JVP, during inspiration, then this is what is called as the Kussmaul sign. The paradoxical rise in the jugular venous pressure during inspiration is what is called as the Kussmaul sign. Okay. Now, is this Kussmaul sign seen in cardiac tamponade? The answer is no. Kussmaul sign is negative in cardiac tamponade. Why is that so? It is because though there is some amount of tamponade, the extrathoracic pressures are still transmitted to the heart. Now, since these pressures are still transmitted to the heart, what happens is that there will still be a fall of the JVP during inspiration. Unlike constrictive pericarditis where the pressures are not transmitted because of a hardened rock-like pericardium. Okay, so Kussmaul sign is negative in cardiac tamponade. Fine. So till here, okay. Now let us look at the ECG. What are we seeing here? We are seeing alternate QRS complexes to be small and big, right? Alternate QRS complexes to be small and big. So the height of the QRS complex varies, and this is what we call as the electrical alternance. This is what we call as the electrical alternance. So electrical alternance is a characteristic feature of cardiac tamponade. Fine. Now let us look at the echo sign. The echo signs of cardiac tamponade are, the earliest sign is, what happens in cardiac tamponade is that there is systemic congestion. So there is increased plethora of the IVC. There is increased plethora of the IVC. So this is the earliest sign which is seen in cardiac tamponade. Now let us look at other signs. What is this showing? This is basically showing that the heart is there in the pericardial cavity, but since it is surrounded by such a huge amount of fluid, the heart basically swings. So this is what we call as the swinging heart. So swinging heart is a sign of cardiac tamponade or massive pericardial effect. Okay. Now let us look at these echo pictures. In these echo pictures, can you see that during systole, let us look here. This is the RA, this is the RV, LV and the LA. So during systole, what happens? There is RA systolic collapse, which is pointed by the arrow here, right? There is some portion of the RA which is collapsing, right? There is some portion of the RA which is collapsing. So RA systolic collapse is what we see in cardiac tamponade, followed by RV diastolic collapse. Right? So RA systolic collapse and RV diastolic collapse are the other two signs which are seen in cardiac tamponade. Now, let us look at this other flow velocity variation, right? So, what are we seeing here? Let us see first the tricuspid valve. Now, what happens in the right side of the heart? In the echo, you use a Doppler to see the flow velocity across the valve. So, you see the flow velocity across the tricuspid valve as well as the mitral valve. So, across the tricuspid valve, what happens, right? So, across the tricuspid valve, you can see that the flow velocity is higher during inspiration and lower during expiration. So, across the tricuspid valve, the inspiratory flow velocity is higher during inspiration, or the inspiratory flow velocity is increased and the expiratory flow velocity is decreased. But during inspiration, if you just look at the mitral valve, during inspiration, over the mitral valve, the inspiratory flow velocity is decreased and the expiratory flow velocity is increased. Why is that so? It is the same concept that we had studied before, right? It is the same concept that we had studied before. Let us see this with the help of this diagram. So, during inspiration, what happens? Just now I had explained to you that there will be increased venous return to the right side of the heart, right? So, there will be septal bulge towards the left side. So, what happens to the flow across the tricuspid valve? The tricuspid valve is between the RA and RV and the mitral valve is between the LA and LV, right? So, during inspiration, what happens? There is increased flow across the right side. So, the inspiratory flow velocity increases and the expiratory flow velocity decreases. Now, because of the bulge which happens, or the septal bulge which happens to the LV, the inspiratory flow across the mitral valve will reduce, correct? The flow across the mitral valve will reduce. So, this is what is seen in the echo, and this is another important sign which is seen in cardiac tamponade, right? So, now we have looked at all the echo findings of cardiac tamponade. Now, what is the treatment for cardiac tamponade? The treatment would be to do a subxiphoid. As you can see here in this line diagram, you take a subxiphoid approach and you drain out the fluid, pericardiocentesis. Right, so you do a subxiphoid approach and you drain out the fluid. So this is about cardiac tamponade for you. So we have learned about what all? We have learned about the Beck's triad, we have learned about what are all the clinical signs and the JVP findings you can see in cardiac tamponade, the ECG and the echo findings. Now let us move on to the last of the pericardial diseases, which is the constrictive pericarditis. Constrictive pericarditis. Okay. So the basic thing that you should know here is the basic pathophysiological difference between constrictive pericarditis and cardiac tamponade. Now we all know that cardiac tamponade is because of fluid accumulation around the pericardium. The fluid can be due to multiple reasons. How is constrictive pericarditis different from cardiac tamponade? So in conditions such as tuberculosis or malignancies, conditions such as tuberculosis and malignancies, when there is an infiltrative process, what happens is that there is infiltration of the pericardium and the pericardium becomes a rock-like or hardened, stiffened, rock-like structure. So there is a rock-like structure which occurs because of this infiltration. So this is what is referred to as the constrictive pericarditis. So you have a small heart and you are surrounded by a thickened rock-like structure which constricts the heart, and that's why it's called as the constrictive pericarditis. Right? So most importantly, what you will have to know is the JVP findings and the JVP difference between constrictive pericarditis and cardiac tamponade. So what you have to know is the basic JVP difference between constrictive pericarditis and cardiac tamponade. So first things first, can you see in this JVP that there is a prominent X descent and a Y descent, and this is what we call as the W sign on the JVP. So there is a prominent X descent and a prominent Y descent. Let us understand why. So with the help of this line diagram, let us understand why. So first thing is that what is the X wave due to? X wave is due to atrial relaxation and Y wave is due to atrial filling. Right? So why is there a prominent X wave? Why is there a prominent X wave? Is because this constrictive pericarditis will cause what? It causes a high pressure, right? It causes a high pressure and the RA is relaxing against a stiff ventricle because of the high pressure from outside. Now since the RA is relaxing against a stiff ventricle, what happens to its relaxation? The pressure gradient will be high. So the X wave is because of atrial relaxation and the Y wave is because of atrial filling. So there is an exaggerated X descent and Y descent which we call as the W sign. So let us understand why there is an exaggerated X descent. So what happens in constrictive pericarditis is that there is an external pressure that is generated and the ventricle is not able to relax completely during diastole. That means that when the atria is trying to relax, there is a high pressure gradient because of this non-compliant ventricle. So this high pressure gradient causes an exaggerated X descent. Fine. The first thing that you'll have to remember is that there is an exaggerated X descent and a Y descent, and this is what we call as the W sign. Okay. So what is the X wave due to? X wave is due to atrial relaxation. And what is the Y wave due to? It is due to atrial emptying. So, in constrictive pericarditis, why do you have a prominent X descent? So, in constrictive pericarditis, the reason why you have a prominent X descent is because the ventricle is not able to relax during diastole, and when the atria begins to dilate, there is a high pressure gradient that is present. So, that's the reason why the X descent is exaggerated in constrictive pericarditis. So what happens to the Y descent? What happens to the Y descent? Y descent is due to atrial emptying, or the flow of blood from the atria to the ventricles is the one which is responsible for this Y descent. So what happens is that initially when the blood flows from the atria to the ventricle begins to dilate. But towards the end of the diastole, the ventricle goes and hits this rock-like pericardium in constrictive pericarditis. So, once it goes and hits this rock-like pericardium, there will be a complete stoppage of flow. That's the reason why in the initial part of diastole, there will be an exaggerated Y descent. So, that is the reason why there is an exaggerated X and Y descent which is seen in constrictive pericarditis. This is in essential different from cardiac tamponade where there is an absent Y. Let us look at the Kusumal sign. Just now we have learnt that the Kusumal sign is the paradoxical inspiratory rise in the JVP. So, this Kusumal sign is basically the paradoxical inspiratory rise in the JVP. Now, why is this Kusumal sign seen in constrictive pericarditis? So, in constrictive pericarditis, we know that the thoracic pressures are not transmitted to the heart because of a rock-like pericardium which is encasing the heart, right? A cage-like pericardium which is encasing the heart. So, the pressures will naturally not be transmitted. So, will there be an inspiratory fall in the JVP if the pressures are not transmitted? Inspiratory fall in the JVP will not be there because the pressures are not transmitted. So, if the pressures are not transmitted, this is what results in what is called as the positive Kusumal sign which is seen in constrictive pericarditis. Okay. So, till now, okay. Do you see pulsus paradoxus? Yes, pulsus paradoxus can be seen in 1/3 of the cases of constrictive pericarditis. Fine. Let us look at the cardiac catheterization findings. Now, this is what we have to focus on. We have to focus on the RV pressure, right? We have to focus on the RV pressure. Now, what is the sign that is seen here? This is looking like the square root sign. This is what we call as the square root sign. So, what happens is that this is what we call as the square root sign, or the other name is the dip and plateau sign. Dip and plateau sign. So, this is basically nothing but the representation of the Y wave on the cardiac catheterization. So, what happens is that when there is filling of blood from the atria to the ventricles begin to dilate. The ventricles begin to dilate up to a point where it goes and hits this rock-like pericardium. So, the pressure increases and suddenly there is an abrupt cessation of flow and there is a plateau. And this is what we call as the square root or the dip and plateau sign. Okay. Now, ECG, what are the ECG findings? You will find the same findings as you seen in cardiac tamponade. You find electrical alternance. Chest X-ray. Can you see here in this chest X-ray that there is a thin white rim which is surrounding the heart? This is nothing but pericardial calcification. This is nothing but pericardial calcification which is seen in constrictive pericarditis. Fine. The echo, on the echo you find the similar findings that you see on cardiac tamponade. Two other terms that you have to remember is your annulus reversus and annulus paradoxus. We will not be going into the details of this echo findings, you will just have to remember the terms, which is annulus reversus and annulus paradoxus is a finding which is seen in constrictive pericarditis. Fine. So, what would be the treatment? The treatment would definitely be a surgical management where you will have to do a pericardiotomy so that you relieve the pressure and you do a stripping of the pericardium so that the pressure is relieved. Okay. So, this is about cardiac tamponade. So, this is about constrictive pericarditis. Now, let us see the difference between cardiac tamponade and constrictive pericarditis. Okay. Let us look at the various differences between cardiac tamponade and constrictive pericarditis. So, pulsus paradoxus is seen in cardiac tamponade. Yes. Is it seen in constrictive pericarditis? Yes, in 1/3 the cases. What happens to the X descent? It is exaggerated in both. What happens to the Y descent? The Y descent is absent in tamponade. It is increase in constrictive pericarditis. Will you find a pericardial knock in tamponade? No, you find a pericardial knock in constrictive pericarditis. You find low voltage complexes in cardiac tamponade? Yes, in constrictive pericarditis also. Electrical alternance is seen in both. What happens to the echo? Thickening of the pericardium and respiratory variations in inflow velocity. Thickening of the pericardium is seen in constrictive pericarditis, and respiratory variations in velocity is seen in cardiac tamponade. Okay. So, this is in essential how do you differentiate between cardiac tamponade and constrictive pericarditis. So, with this we have come to the end of our lecture on pericardial diseases. I hope you have understood the different types of diseases and the mechanisms behind which each of the JVP findings or the auscultatory findings are seen, and let us meet in the next session. Thank you.